So imagine it's 3 in the morning.
Right. The classic bad shift.
Exactly. You are in the back of an ambulance,
Yeah.
and you're just tearing down this rain-slicked highway at, like, 70 miles an hour.
Hmm.
The lighting is terrible. It's casting these weird, jarring shadows across this cramped little space. The suspension is just destroying your knees on every pothole.
Oh, yeah. It's a completely hostile environment.
It really is. And, in your hand, you are holding this tiny 2 milliliter glass vial.
Right?
And if you push the right amount of the clear liquid inside that vial into your patient's vein, they live. They actually
Yeah.
live to see the sunrise.
Mm-hmm.
But if you push, even a millimeter too much, or if you push it too fast, or if you misread the tiny printed label in the dark, they die.
Yeah, it's that absolute.
So welcome to our deep dive into the source material. If you are listening to this right now, you are a paramedic student who is just about to step into your clinical training.
Which is a huge deal.
It's massive. You are standing on the precipice of this completely life-altering transition.
Yeah, you're transitioning from, the pristine black and white world of a textbook to the muddy, chaotic reality of the street.
Right. And today, we're taking a huge stack of clinical guidelines, pharmacology basics, and, well, the deep, intricate physiology of pharmacokinetics.
We're translating all of that dense science into your new reality.
Exactly. We're going to explore what actually happens when you introduce a powerful chemical into a human body that is essentially already spiraling toward death.
It's a lot of pressure.
Okay, let's unpack this because the stakes literally could not be higher. Before you even, touch a syringe, we really have to talk about the absolute nightmare scenario.
Right, the baseline of safety.
Yeah. In pre-hospital care, there was this concept known as the 4 fatal wrongs.
Mm-hmm.
As a paramedic, you have this incredible amount of autonomous power.
You do. You're operating without a doctor standing right over your shoulder.
Right. But with that comes the very heavy burden of potentially ending a life if you succumb to cognitive overload.
Which happens to the best of us.
It really does.
Okay.
So the 4 fatal wrongs are, well, administering the wrong medication, administering a medication via the wrong route, giving the incorrect dose, or failing to follow the correct technique for administration.
And the terrifying thing is, any single one of those errors initiates this catastrophic chain of events.
Yeah, there's no taking it back.
Exactly. Pharmacology at this level, it isn't just about, handing someone a pill and telling them to call a clinic in the morning.
Right. You're not a pharmacist filling a prescription.
No, you are forcibly altering the fundamental biochemical function of a living organism during its most vulnerable, unstable moment.
That's intense.
It is. You might be aggressively treating a life-threatening illness or deploying an antidote to reverse a deadly toxic exposure.
Or, desperately trying to manage the cascading adverse effects of a cocktail of medications the patient took at home.
Exactly. You are intervening in their biochemistry in real time, and you're doing it completely without a safety net.
It's just an overwhelming responsibility.
It really is.
And before you can even think about pushing a drug, you need to understand the language of the tools you're using. The evidence backing them up, and the immense legal weight of that little glass vial.
You really have to know exactly what's in your hand.
Right. And medications in the United States, they have this serious identity crisis.
Yeah.
They don't just have one name, they have 3.
Which, honestly, for a profession that relies on split-second communication, it just seems like a recipe for absolute disaster.
Yeah, it's wildly confusing.
Yeah.
But the nomenclature system is complex because it maps the life cycle of the drug, right?
Exactly. It begins with the chemical name, and this is purely for the laboratory.
Right.
It describes the exact atomic level molecular structure of the compound. So, for instance, the diuretic you will eventually carry, it has a chemical name of 4-chloroanfurfuryl 5-sulfamoyl-anthranilic acid.
Which is, frankly, absolutely useless to me in the back of a rig.
Completely useless.
I can just imagine my patient crashing and me screaming at my partner, quick, draw 40 milligrams of 4-chloroanfurfuryl whatever.
Right, and by the time you finish the sentence, the patient has already coded.
Exactly. It's ridiculous.
And that is precisely why the chemical name is just abandoned the moment the drug moves toward clinical trials.
Thank goodness.
Yeah, it gets replaced by the non-proprietary or generic name.
Right, the generic.
Now, this name is proposed by the original manufacturer, but it has to be heavily scrutinized and approved by the U.S. Adopted Names Council and the World Health Organization.
So it's very standardized.
Highly standardized. And the critical takeaway for you, this student, is that generic names are engineered with a specific linguistic code.
Okay, what kind of code?
Well, they use a stem, So a suffix or a prefix that explicitly links the medication to other drugs in the exact same pharmacological class.
Oh, right. Like midazolam, diazepam, lorazepam,
Exactly.
where they all end in that repam or elam sound.
Yeah.
So if I'm, reading a protocol and I see a drug I've never heard of before, but it ends in DPAM, my brain instantly categorizes it.
Right. You know what neighborhood you're in.
Yeah. I go, okay, this is a benzodiazepine. It's going to act on the central nervous system to sedate this patient or stop their seizure. It's basically a built-in cheat code.
It is a vital mental shortcut, but you must treat it with caution.
Why is that?
Because pharmacology is just full of exceptions. Different classes of drugs might occasionally share a vaguely similar stem, or an older drug might defy the modern naming conventions entirely.
So you can't just rely on the cheat code blindly?
No, you can't. The stem gives you the neighborhood, but pure memorization gives you the exact address.
Okay, that makes sense.
And finally, we reach the brand or proprietary name.
The one we actually see on the commercials.
Right. This is chosen by the manufacturer strictly for marketing, copyright, and patent purposes, and it's approved by the FDA.
So, mapping our earlier example, the chemical nightmare becomes the generic furosemide, which is then marketed under the highly recognizable brand name Lasix.
Exactly. Lasix.
And Lasix is punchy, it's memorable. But here is where the reality of human psychology crashes into this system.
Because there are thousands of drugs on the market.
Exactly.
Yeah.
Inevitably, we end up with drugs that sound incredibly similar or look almost identical when printed on a tiny label.
It's a huge problem.
If I'm stressed out, exhausted, and reading a vial under a dim dome light at 3 a.m., I could easily swap 2 drugs and kill someone.
And the industry recognized this cognitive vulnerability, so they implemented a visual interrupt known as tall man lettering.
Oh, I love tall man lettering.
It's a brilliant psychological trick.
It really is. It's basically the pharmaceutical company text yelling the most important distinguishing part of the word at you.
Yes, precisely.
Take the antihistamine diphenhydramine, which everyone knows is Benadryl, and compare it to dimenhydrinate, which is Dramamine for motion sickness.
Right.
On a standard lowercase label, they look like twins.
They look exactly the same.
And if my patient is having a massive allergic reaction, their airway is literally swelling shut, and I accidentally give them Dramamine instead of Benadryl, they die.
They absolutely die.
So the label prints it as diphenhydramine, capitalizing the AMINE,
Right.
and dimenhydrinate, capitalizing DRINATE,
It forces your brain out of automatic processing mode.
which is so crucial when you're tired.
Exactly. When we read familiar words, we don't actually read every single letter.
We just recognize the shape of the word.
Yeah, we read shapes, and tall man lettering violently disrupts that shape. It forces your eyes to pause, your brain to engage critical thinking, and your mouth to pronounce the distinct syllables.
Wow. But, knowing the name of the drug and reading it correctly, that's really only the absolute baseline.
It's the bare minimum.
Yeah. You also need to know why you are authorized to give it and how strongly the medical community actually believes it will help your patient.
Right, you aren't operating on gut instinct out there.
No, not at all. Your protocols are built on a rigid hierarchy of evidence, primarily dictated by the American Heart Association, the AHA,
And memorizing the AHA classifications is simply non-negotiable for a paramedic.
because it dictates your entire scope of practice.
Exactly. The system grades every single intervention. So let's start with Class 1.
Okay, class line.
Class I indicates an overwhelming consensus of strong, undeniable scientific evidence.
Meaning there's no debate?
Zero debate. Multiple randomized controlled trials have proven that the benefit of this medication vastly outweighs the risk.
So if a patient presents with a specific condition and a drug is a class I recommendation, what happens if I just decide not to give it?
Withholding that drug without a valid contraindication is essentially malpractice.
Wow.
Yeah, you just do it. It's the gold standard.
But medicine isn't always black and white, is it?
Far from it. And that brings us to Class 3.
Class 3, okay.
This indicates moderate evidence. The weight of the scientific evidence is still heavily in favor of efficacy.
Right.
But there might be slight conflicting data, or maybe the trials just weren't as massive. Still, it is considered a reasonable and generally safe action.
Okay, so it's a solid choice, even if it's not the gold standard.
Exactly. Then, Class 2I drops the confidence level down to weak evidence.
Weak evidence. That sounds a little sketchy.
Well, the usefulness is just less established. It might be supported by expert opinion or smaller case studies, rather than massive double-blind trials.
So when would you even use a class I?
You might consider it if other therapies are actively failing, but it is definitely not a guaranteed success.
Got it. And then we drop off the cliff into the do not do this territory.
Okay, right. Class 3, no benefit, means exactly that.
It just doesn't work.
The evidence simply does not support that the intervention helps. It's a complete waste of time and resources.
But there's a worse one, right?
Yes, the terrifying one is Class 3, harm.
Harm.
This classification means there is robust evidence proving that the risk of giving this medication is significantly greater than any potential benefit.
Okay, let's paint a picture of that because that's intense.
Yeah.
Imagine you have a veteran medic, right? He's been on the job for 30 years. He tells you, hey kid, back in the day, we always pushed this specific antiarrhythmic for this weird heart rhythm. It works, trust me.
Right.
But you look at the current AHA guidelines, and that exact practice is now listed as Class 3 harm because recent massive studies proved it actually induces fatal secondary heart rhythms.
Yes. And as a new medic, you have to have the knowledge and honestly the courage to look at that veteran and say, no, the evidence says we will kill them.
That sounds like a really tough conversation to have in the back of a moving ambulance.
It is, but it happens more often than you'd think. Medicine evolves, and what was standard practice a decade ago can become a lethal error today.
That's wild.
And this strict adherence to evidence, it's also tied to intense legal regulation.
Right, because we're carrying narcotics.
Exactly. The modern paramedic operates under a system built upon a century of trial, error, and immense tragedy.
Like the 1938 Food, Drug, and Cosmetic Act, right?
Yes, that established the FDA's enforcement authority after untested toxic solvents killed over 100 people.
But the law that dictates your daily operational life is the Controlled Substances Act of 1970.
Right. This act categorizes drugs with the potential for abuse and addiction into 5 schedules.
Okay, let's break those down. Schedule E has a massive abuse potential, and at the federal level, no recognized medical purpose.
Right. Things like heroin, LSD, or despite state-level legalizations, marijuana.
So we aren't carrying those on the ambulance.
No, definitely not.
But you are absolutely going to carry Schedule II medications.
Schedule II medications are the paradox of emergency medicine.
How so?
Because they have an extreme potential for severe psychological or physical dependence, but they have a highly legitimate, irreplaceable medical purpose.
Oh, like pain management.
Exactly. These are your potent opioid analgesics, so fentanyl, morphine, hydromorphone.
And think about the environment you're in.
Yeah.
You're carrying a plastic box full of highly addictive, intensely valuable narcotics. You are in a vehicle with a flimsy lock, often parked on a dark street, surrounded by chaos, while you are inside an apartment doing CPR.
It's a huge liability.
The security requirements aren't just bureaucratic red tape. They are life-or-death necessities.
Absolutely. All Schedule II through V medications mandate locked storage.
And that's pretty strict now, right?
Oh, very. And many progressive EMS systems, this means a biometric safe bolted directly to the floor of the ambulance, requiring a fingerprint and a PIN to even open.
Wow.
Furthermore, the chain of custody is absolute.
Meaning every drop is tracked.
Every single milligram. When the agency orders a vial fentanyl, it is logged. When you check out your drug bag at the start of your shift, you sign for it. When you administer 50 micrograms to a patient, you document the exact time, the dose, and the physician who ordered it.
But what if I only need half the vial? I mean, I can't just toss the remaining fentanyl into the trash can or just squirt it onto the floor of the rig, right?
Never. That requires a controlled wasting procedure.
How does that work?
You must physically destroy the remaining medication, usually by injecting it into a specialized neutralizing pouch or down a dedicated biohazard sink. And you must have a licensed witness watch you do it. Then both of you sign a legal document testifying to the destruction.
It's intense. Let me throw a real-world scenario at you, though.
Okay, let's hear it.
I was reading a case study where a medic was treating a patient with a shattered femur. Horrific pain.
Ouch. Yeah.
The medic draws up a standard, heavy dose of a potent opioid from their locked box, pushes it into the IV, and waits. 5 minutes go by. The patient doesn't even blink. They are still screaming in absolute agony. No drop in blood pressure, no pupil constriction, nothing. What is happening there?
Well, while human physiology varies, an absolute zero response to a massive dose of a Schedule II narcotic, that should trigger an immediate blaring alarm in your mind regarding drug tampering and diversion.
Diversion meaning someone stole the drug.
Yes. Healthcare professionals are not immune to addiction.
Unfortunately, no.
A compromised provider might use a microscopic needle to pierce the rubber stopper of a fentanyl vial, extract the narcotic for their own use, and replace the missing volume with perfectly clear, sterile saline to make the vial look full.
So it looks completely normal.
Exactly. They place it back in the box. Weeks later, you pull that vial for a patient with a shattered femur, and you are unknowingly injecting them with tap water.
That is just horrifying.
It is a profound betrayal of the patient. This is why, as a student, you must train your eyes to inspect every single vial, ampule, and pre-filled syringe before you ever draw medication.
What exactly am I looking for?
Look from the plunger hits the bottom of the syringe.
Exactly. We are now entering the microscopic battlefield. We are talking about pharmacodynamics. The drug is in the blood. What is it actually doing?
To understand pharmacodynamics, you have to master receptor theory.
Okay, receptor theory.
Imagine the surface of every single cell in the human body is studded with thousands of complex, folded proteins.
Okay.
These are receptor sites. They function as highly specialized three-dimensional locks.
And the body manufactures its own endogenous keys to fit those locks.
Right.
Hormones, neurotransmitters like adrenaline or dopamine, they just float around, find the lock, and turn it to make the cell do something.
Yes. When a natural key binds to a receptor, it triggers a profound intracellular cascade.
Like what?
It might pry open an ion channel, allowing sodium or calcium to flood into the cell, which triggers an electrical impulse.
Oh, like making a heart muscle beat.
Exactly. Or it might activate a secondary messenger protein deep inside the nucleus, telling the cell to manufacture a new enzyme. Or it might slam the brakes on a cellular process, stopping the cell from secreting a fluid.
So a medication, an exogenous chemical manufactured in a lab, it's basically a master key cut by a locksmith to perfectly mimic the body's natural keys.
That is exactly what an agonist medication is.
An agonist.
It binds to the receptor and actively turns the lock, initiating that cellular response.
But mastering agonists requires understanding 4 distinct quantifiable variables, right?
Yeah.
Affinity, threshold level, potency, and efficacy.
Correct.
Let's break those down. Let's start with affinity.
Affinity is the chemical magnetism between the drug and the receptor. It dictates how perfectly the key fits the lock.
So if a drug has high affinity,
It actively seeks out that specific receptor and binds to it with incredible strength, ignoring all other receptors.
and if the affinity is low,
The drug molecules might bounce off or bind weakly and detach quickly.
got it. But just having the key in the lock isn't enough to open the door. You need the threshold level.
Correct. The threshold level is the critical mass.
What do you mean by critical mass?
One single molecule binding to one single receptor won't do anything noticeable.
Right.
You have to occupy a specific percentage of the cell's total receptors before the intracellular cascade becomes powerful enough to create a measurable clinical change in the patient's condition.
So threshold is the tipping point where you actually see something happen on the monitor.
Exactly.
Okay, what about potency?
Potency is a measure of concentration. How many milligrams or micrograms of this chemical do you need to dump into the bloodstream to reach that threshold level?
Okay.
If a drug is highly potent, you only need a microscopic fraction of a dose. Fentanyl has immense potency. 50 micrograms will achieve what takes 10 entire milligrams of morphine to do.
Wow, that's a massive difference. And finally, efficacy, the holy grail.
Efficacy is the ultimate ability of the drug to actually achieve the desired therapeutic outcome.
Like, did the blood pressure drop? Did the seizure stop? Did the pain subside?
Yes. A drug can have high affinity, reach the threshold, be incredibly potent, but if it doesn't actually fix the underlying physiological problem, its efficacy for that specific condition is zero.
Here's where it gets really interesting, though. Because as a stressed-out medic, human nature dictates that if a little bit of a drug is good, a massive dose must be incredible.
That's a very dangerous assumption.
Right, like if 2 milligrams of an agonist fixes the pain a little, 20 milligrams will make them feel amazing. But the cells literally rebel against that logic through what's called the limit of change.
The limit of change is a hard biological ceiling.
A ceiling.
A cell only has a finite, mathematically set number of receptor sites on its membrane. Let's say a cell has 1,000 receptors.
Okay, 1,000 shares.
You push an agonist and it binds to all 1,000. At that exact millisecond, the maximum capacity of that cell is reached. It is operating at 100% output.
So if I push another 50 milligrams of the drug into the FE,
The drug molecules have nowhere to sit. The game of musical chairs is full. Pushing more of the agonist does absolutely nothing therapeutic.
Yeah.
You cannot force the cell to perform beyond its biological
Oh,
maximum.
wait, those excess unbound drug molecules, they don't just disappear.
No, they don't. They circulate in the blood, build up to toxic levels, and begin forcing their way into secondary non-target receptors.
Oh, which triggers a cascade of dangerous unintended side effects.
Exactly.
Okay, so agonists are the accelerators. They turn the system on.
Mm-hmm.
But half the time in EMS, we aren't trying to start a physiological process. We're desperately trying to stop one.
Right, like a heroin overdose.
Yeah. A patient overdoses on heroin, their respiratory drive is shutting down. We need to slam the brakes.
And this is the realm of antagonist medications.
Antagonists.
They don't turn the lock, they jam it.
Okay, explain that.
Antagonists are the biochemical shields. They bind to the receptor, but lack the specific molecular shape required to trigger the intracellular cascade.
So they fit in the lock, but they can't turn.
Right. Their entire purpose is to sit in the lock and physically block an agonist from getting in.
And we divide them into two heavily distinct categories: competitive and non-competitive antagonists.
Yes.
I always visualize competitive antagonists as an incredibly violent, high-stakes game of musical chairs.
That's a very accurate way to look at it.
Let's take the heroin overdose. Heroin is an agonist, right?
Yes.
Its molecules are currently sitting in the chairs, the opioid receptors in the brainstem telling the lungs to stop breathing.
Mm.
The patient is turning blue.
Mm-hmm.
You, the medic, push naloxone, which is a competitive antagonist.
Right.
The naloxone floods into the brainstem and literally fights the heroin molecules for the chairs.
And the winner of that fight is determined by two things: affinity and concentration.
Nope.
Naloxone has a profoundly higher affinity for the opioid receptor than heroin does. It acts like a magnet, ripping the heroin out of the receptor site and taking the seat for itself.
So the naloxone is sitting in the chair, not activating the cell, but preventing the heroin from sitting back down. And because the heroin can't attach, the brainstem suddenly wakes up, realizes the body is suffocating, and the patient takes a massive gasping breath.
Exactly, but remember, it's competitive.
Right.
The heroin is still floating around in the blood, waiting for a chair to open up.
So if the naloxone wears off before the liver metabolizes the
The heroin sits back down, and the patient stops breathing again. It's a constant, dynamic battle.
That's why you have to keep monitoring them.
Exactly.
But then you have non-competitive antagonists. These are terrifying.
They really are. They don't just sit in the chair, they destroy the game entirely.
How do they do that?
A non-competitive antagonist permanently alters the molecular structure of the receptor site itself.
It's like a person walking into the game of musical chairs, sitting down and injecting industrial-strength superglue between themselves and the seat.
Yeah.
They are never getting up.
A perfect analogy. Once they bind, they permanently deactivate the receptor. And the terrifying part for a toxicologist or a paramedic is that you cannot overcome a non-competitive antagonist by simply administering a massive dose of an agonist.
Right, because if they are glued to the chair, flooding the room with a million other people won't dislodge them.
Exactly. The block is absolute, and it lasts until the cell eventually dies or naturally metabolizes the entire receptor complex and spends days manufacturing brand new, fresh receptors.
That is wild. But wait, does every single drug we carry work by interacting with these protein locks? Because we carry some things that seem to work through brute force chemistry, not delicate cellular keys.
You're touching on a vital exception. Many critical drugs bypass receptors entirely.
Okay, like what?
Look at chelating agents.
Chelating agents.
If a child swallows lead paint or an industrial worker is exposed to heavy metals, those metal ions circulate in the blood, destroying tissues. Chelating agents are intravenously infused molecules that physically hunt down the heavy metals in the bloodstream.
Wow.
They chemically bind to the metal ion, wrapping around it like a microscopic cage, creating a massive inert compound that the body recognizes as waste and flushes out through the kidneys.
It's like molecular handcuffs. What about diuretics? We use those to pull fluid out of lungs in heart failure.
Diuretics bypass receptors by manipulating the laws of physics, specifically osmosis.
Osmosis, right.
They alter the concentration of sodium and potassium inside the tiny tubules of the kidneys.
Okay.
By dumping sodium into the urine, they create a hypertonic environment that literally sucks excess water out of the surrounding body tissues into the blood and eventually into the bladder.
That makes sense.
Yeah.
And my absolute favorite brute force drug, Sodium bicarbonate.
Oh, sodium bicarbonate is pure, unadulterated acid-base chemistry.
Yeah, let's talk about that.
If a patient is in cardiac arrest, their body isn't clearing carbon dioxide. They become profoundly acidotic. Their blood fills with toxic hydrogen ions.
It's essentially turning to acid.
Exactly. When you push sodium bicarbonate, it dissociates in the blood, releasing free bicarbonate ions. These ions don't look for receptors. They simply collide with the free-floating hydrogen ions, bind to them, and chemically convert the toxic acid into harmless water and carbon dioxide.
It is an immediate, violent neutralization of the blood's pH.
Yes, it is.
Okay, so we've established what the drug does at a cellular level and why it works. But out on the street, the most critical variable is when.
Time is everything.
Right. When will this patient stop seizing? When will they start breathing again? The speed of onset is entirely dictated by how you put the drug into the body.
Yes.
This brings us to the logistics of delivery, routes of administration, and bioavailability.
Let's define bioavailability first.
Okay, go ahead.
It's the percentage of the unchanged active medication that actually survives the journey and makes it into the systemic blood circulation.
So in emergency medicine, since we are obsessed with speed, the undisputed gold standard route of administration is intravenous, or AV.
Correct. You take a hollow needle, puncture the skin, enter a peripheral vein, slide a plastic catheter in, and push the drug directly into the venous blood return.
The journey is literally zero.
So the bioavailability is mathematically 100%.
Everything you pushed is instantly available to the heart to be pumped to the brain.
Instantaneous onset, total bioavailability. It is the perfect route.
Right. But getting an IV in a crashing patient is an absolute nightmare.
Oh, it's incredibly difficult.
A textbook assumes a healthy, cooperative patient with, like, garden hose veins.
Right, which never happens.
Never. What if my patient is bleeding to death from a gunshot wound? They're in profound hemorrhagic shock. Their sympathetic nervous system has completely clamped down on every single peripheral blood vessel in their arms and legs just to shunt whatever blood is left to their heart and brain.
Yes, to keep the core alive.
Those veins are flat, empty, and functionally invisible.
Or consider the reality of treating the opioid epidemic. You have a patient who has been injecting heroin into their arms, their legs, even their neck for a decade.
Right.
Their veins are completely destroyed. They are thick, scarred cords of sclerosis. You literally cannot get a needle into them.
And in these chaotic, critical moments, you cannot spend 10 minutes repeatedly stabbing a dying patient in a dimly lit room. You need a fast, reliable alternative.
And this is where the intranasal, or AN, route has fundamentally revolutionized modern EMS.
It is the absolute hero of the jump bag.
It really is. The anatomy of the human nasal cavity makes it a phenomenal delivery route.
Okay, explain how it works.
You take a liquid medication, attach a specialized, spongy mucosal atomizer device to the syringe, and violently push the plunger. The atomizer forces the liquid through microscopic pores, converting it into a fine, expanding mist inside the nostril.
Why the mist? I mean, why not just squirt the liquid in there?
Because a mist covers a vastly larger surface area. And the mucosal membrane inside the nose is paper thin, sitting directly on top of a massive, dense bed of capillary.
No, the mist coats the membrane.
And the medication instantly diffuses across that single layer of cells straight into the bloodstream, completely bypassing the digestive system.
That's incredible. And the bioavailability.
For highly lipophilic drugs, it approaches 100%. The speed of onset rivals IV administration.
Wow. So if you have an actively seizing child, trying to start an IV on a thrashing little arm is nearly impossible.
Completely impossible.
But you can easily spray a mist of IN midazolam into their nose, and the seizure will often break within 60 seconds.
Yes. Furthermore, it requires 0 needles.
Which is a huge safety factor for us.
Massive. If you are wrestling with a combative overdose patient, the risk of a contaminated needle stick injury to you or your partner is high. In delivery, completely eliminates that risk.
It's an incredible tool. But sometimes in the end isn't appropriate for a specific drug, and IV is still impossible. So we fall back to intramuscular, or IM, injecting deep into the thigh or the shoulder.
IM relies on the vascularity of skeletal muscle.
Right.
You inject a depot of the drug deep into the muscle fibers, and it slowly absorbs into the surrounding capillaries.
And what's the bioavailability like for that?
Generally excellent, around 75% to 100%, and the onset is reliable, usually within 5 to 15 minutes.
But there's a huge catch with IM, right? It relies heavily on perfusion,
Exactly. We go back to your hemorrhagic shock patient.
the one clamping down their vessels.
Right. If their body has clamped down on blood flow to their limbs to save their core organs, there is virtually no blood flowing through that thigh muscle.
Oh, wow. So if I inject something there,
You can inject all the epinephrine you want into that muscle, but it's just going to sit there in a stagnant pool. It will never reach the heart.
which leaves us with the most aggressive, medieval-sounding route in the protocol book, intraosseous, or IO.
It does sound medieval.
We're literally taking a power drill and boring a hole into the patient's skeleton.
It sounds barbaric, but it is one of the most elegant, life-saving procedures you will ever perform.
Okay, explain how drilling into a bone saves a life.
Well, the cortex, the hard outer shell of a long bone like the tibia, protects the medullary cavity inside. This cavity is filled with spongy bone marrow. But more importantly, that marrow contains a massive, dense network of venous sinusoids.
It's basically a giant, non-collapsible sponge made of veins.
Precisely. Unlike a vein in the arm, the IO space cannot collapse, no matter how severe the shock or blood loss is.
Because the hard bone keeps it open.
Yes. So, using a specialized battery-powered drill, you drive a hollow steel needle through the hard bone and into that spongy marrow.
You actually feel a distinct pop as it enters the space.
You do. And once you are in, any fluid, any medication, or any blood product that you can push through a standard IV can be power flushed directly into the IO space.
And how fast does it hit the system?
It enters the central circulation within seconds.
It's incredibly durable, too. You can leave it in for 24 hours.
Mm-hmm.
But there has to be a limitation, right?
The primary contraindication is anatomical integrity.
Meaning the bone has to be whole.
Exactly. If the patient has a fractured tibia, you absolutely cannot drill an IO into that bone below the fracture.
What happens if you do?
When you push fluid under pressure into the marrow, it will just follow the path of least resistance, leak out of the fracture site, and flood the surrounding muscle compartments, causing horrific swelling and tissue death.
That sounds like a disaster.
It is. The bone must be intact.
Okay, I'm going to ask about a route I used to see on every single medical drama from the 90s.
Let me guess, pushing drugs down the tube.
Yes. The patient is coding, someone shoves a breathing tube down their throat, and the doctor yells, "Push the epi down the tube." Endotracheal administration. Do we still do that?
It is largely a historical relic.
So we don't do it.
We have almost entirely abandoned it. The theory was that the massive surface area of the lungs would absorb the drug instantly.
Makes sense on paper.
But the reality is that absorption across the alveolar tissue is wildly unpredictable, especially if the lungs are filled with fluid, blood, or pneumonia.
So if paramedic is ever absolutely forced to use it, what are the rules?
If you have absolutely no other access, no IV, no IO, and the drug can't go IN,
Wow.
you can use the endotracheal tube. But because the absorption is so poor, you must administer at least 2 to 2.5 times the standard IV dose.
Wow, more than double.
Yes. Furthermore, you can't just squirt it in. The drug will just stick to the inside of the plastic tube.
Right?
You have to immediately follow the medication with a 5 to 10 milliliter flush of sterile water or saline, and then vigorously ventilate the patient with a bag valve mask to literally blow the liquid deep into the lung bases.
So it's truly a desperate act of last resort.
Completely.
Finally, let's talk about the routes most patients actually understand. Sublingual and oral.
Right.
Sublingual is simple. It's under the tongue. We use it for nitroglycerin tablets during a heart attack. The pill dissolves, hits the dense capillary bed under the tongue, and goes straight into the systemic circulation. But oral administration, swallowing a pill, is an entirely different beast.
It faces the most brutal gauntlet in human physiology: first-pass metabolism.
This is a monumental concept.
It is. When you swallow a pill, it drops into the highly acidic environment of the stomach where it begins to dissolve. It passes into the small intestine where it is finally absorbed across the intestinal wall into the blood.
But that blood doesn't take a straight highway back to the heart.
No. The body is highly suspicious of anything absorbed through the gut.
It assumes everything you eat is potentially toxic.
Exactly. So the venous blood leaving the intestines is shunted into a massive vessel called the portal vein.
Okay.
The portal vein acts as a direct funnel, delivering all of that newly absorbed blood straight into the liver.
The liver is the body's ultimate bouncer, and the portal vein is the velvet rope.
That is exactly what it is. The liver's job is to ruthlessly filter and chemically neutralize foreign substances before they can reach the brain or the heart.
So it sees the drug.
It identifies the newly absorbed medication molecules as foreign invaders. Before the drug ever sees the systemic circulation, the liver aggressively tears apart a massive percentage of the drug molecules, rendering them completely inactive.
And this massacre is first-pass metabolism,
Yes.
which explains a massive discrepancy I saw in my textbook.
About amiodarone.
Yes. If I want to give the antiarrhythmic amiodarone through an IV, the dose is 150 milligrams to go straight to the heart.
Right.
But if a cardiologist prescribes amiodarone as an oral pill for a patient to take at home, the dose might be 400 or even 800 milligrams a day.
Because the manufacturer knows the liver is going to destroy 70% of the drug on the first pass.
That's crazy.
They have to deliberately overdose the pill, packing it with enough extra medication that a tiny therapeutic fraction survives the hepatic toll booth and eventually trickles out of the liver into the inferior vena cava, finally reaching the heart.
Which transitions us perfectly from how we get the drug in to how the body fights back.
Right. Pharmacokinetics.
We are diving deep into pharmacokinetics and metabolism. The very millisecond your carefully chosen, perfectly dosed drug enters the bloodstream, the patient's body actively declares war on it.
It does.
It throws up physical barriers, it deploys chemical traps, and it fires up massive metabolic engines to dismantle the drug.
The human body is a fortress designed for homeostasis. The first line of defense are the cellular barriers, the blood-brain barrier, the blood-placenta barrier, and the blood tests barrier.
What are they exactly?
These are microscopic walls of tightly joined cells designed to keep toxins out of the most critical, sensitive tissues.
So, a drug molecule can't just float through. It has to have the right VIP pass.
Exactly, and the VIP pass is usually lipid solubility.
Lipid meaning fat.
Right. The cell membranes of these barriers are made of fat. Therefore, a drug molecule must be highly lipophilic, fat-soluble, and non-ionic, meaning it lacks an electrical charge, to dissolve through that fatty wall.
Give me an example of how that plays out.
If a patient has bacterial meningitis, an infection inside the brain, you cannot just give them any random antibiotic.
Because?
If the antibiotic is water-soluble, it will bounce right off the blood-brain barrier and circulate uselessly in the plasma while the brain infection rages on.
Oh, wow.
You must select a drug chemically engineered to breach the wall.
But even before it hits those walls, the drug has to deal with the transport system itself, the blood plasma.
Right.
And this introduces a massive hidden variable. Plasma protein binding.
Blood plasma is full of large proteins, primarily albumin.
Okay,
These proteins act like giant floating transport buses.
Buses, I like that.
As soon as a medication enters the blood, a specific percentage of its molecules will immediately crash into these albumin proteins and bind tightly to them.
But here's the catch. A bound molecule is a useless molecule.
Exactly. The protein is far too massive to cross a cell membrane or fit into a receptor site.
Right.
As long as a drug molecule is stuck to the albumin bus, it is pharmacologically inert. It cannot do anything.
So only the free molecules, the fraction of the drug that didn't get a seat on the bus, are actually floating around causing the therapeutic effect.
Correct.
But it's not a permanent trap, right? It's a dynamic equilibrium.
Yes. As the free drug molecules are metabolized and eliminated by the kidneys, the concentration in the blood drops.
And then what happens?
To maintain the balance, the bound molecules slowly detach from the albumin and become active.
Oh, I see.
This means plasma protein binding actually creates a sustained release effect within the blood, giving the drug a much longer duration of action.
Let me push back on this with a clinical scenario, though.
Okay.
What if my patient is a chronic alcoholic, or severely malnourished, or has end-stage liver disease? Their liver isn't manufacturing albumin anymore. They have virtually no proteins in their blood.
You've just identified a critical lethal trap.
How so?
If you give a standard dose of a highly protein-bound drug, say a specific anticonvulsant that is normally 90% bound, you are expecting only 10% of that dose to be immediately active.
Because the rest are on the buses.
Exactly. But in your malnourished patient, the albumin buses don't exist.
Oh, no.
Suddenly, 100% of the drug is free, active, and instantly slamming into the receptors.
So a completely normal protocol-compliant dose just became a massive catastrophic overdose.
Yes. You must assess the overall health of the patient, not just the acute symptom.
And we also have to talk about where the drug hides physically,
Yeah.
specifically in the fat tissue. This is incredibly relevant because we are treating an increasingly obese population.
Adipose tissue is a massive reservoir for lipophilic medications.
How does that work?
When you administer a highly fat-soluble sedative or anesthetic to a morbidly obese patient, the drug rapidly moves out of the blood and sequesters itself deep inside the fat cells.
It just absorbs into the fat like a sponge,
Yes. And because the fat tissue has poor blood flow, it traps the drug.
which blunts the effect.
It severely blunts the initial clinical effect. You might push a heavy dose of a sedative, and the patient is still awake. You are tempted to push more and more just to get them down.
And that works in the short term. But what happens 2 hours later when we hand them over to the ER?
That is the danger. Hours later, as the blood concentration of the drug begins to fall, that massive reservoir of fat acts like a slow drip IV.
Oh, that's not good.
It begins leaching all of that sequestered sedative back into the bloodstream. Long after the initial emergency is resolved, the patient can suffer from massively prolonged, unpredictable, and potentially fatal resedation and respiratory arrest.
The drug literally comes back to haunt them.
Exactly.
So the body is hiding the drug, trapping it on proteins, but eventually it has to destroy it.
Yes, through biotransformation.
And that destruction happens in the liver.
The liver is the ultimate chemical refinery. It utilizes an incredibly complex family of enzymes known as the cytochrome P450 system.
The P450 system.
The primary goal of the P450 system is to take a lipid-soluble active drug molecule and physically tear it apart and rebuild it, converting it into what we call a metabolite.
How does an enzyme actually do that? How does it make a fat-soluble drug water-soluble? Because that's the end goal, right? It has to be water-soluble so the kidneys can pee it out.
The biochemistry is fascinating. The P450 enzymes use oxidation, reduction, and hydrolysis. They literally ram oxygen molecules into the drug's chemical structure, or they rip hydrogen atoms off. They expose polar electrical charges on the molecule.
And what does that do?
By adding these polar groups, they fundamentally alter the molecule's interaction with water. It goes from repelling water to eagerly dissolving in it.
Wow.
Simultaneously, this brutal structural alteration usually destroys the drug's ability to fit into its original receptor. It becomes an inactive, highly water-soluble piece of metabolic trash.
So the P450 system is basically a cellular chop shop.
That's a good way to put it.
It pulls the stolen car into the garage, strips the paint, rips out the engine so it can't drive anymore, and breaks it down into small, recognizable pieces of scrap metal that can be easily hauled away by the garbage trucks.
A vivid analogy, but highly accurate. And those garbage trucks are the kidneys.
Right.
The kidneys filter the blood, pull out the water-soluble metabolites, and excrete them into the urine.
Which brings us to the ultimate timeline of a drug, the half-life.
Yes. Half-life is defined as the time it takes for the liver and kidneys to metabolize and eliminate exactly 50% of the drug currently in the plasma.
But the rate at which they do this follows one of two distinct mathematical rules, right?
Yes. Zero order or first order elimination.
First order elimination makes sense to me. It's proportional.
Yes, the vast majority of drugs follow first order kinetics. The liver and kidneys are incredibly efficient engines. The harder you push them, the faster they work.
Right.
In first order, the rate of elimination is directly influenced by the concentration of the drug in the blood. If you have a massive toxic amount of the drug in your system, the enzymes fire into overdrive, eliminating a huge volume of the drug very quickly.
And as the blood levels drop,
The engines cool down, and the rate of elimination slows logarithmically. It's a smooth curve.
but zero order elimination is completely wild. It defies logic.
Zero order elimination is a rigid, terrifying bottleneck.
How so?
In the system, the body's enzymes become instantly saturated. They can only process a fixed, absolute amount of the substance over a specific period of time, completely regardless of how much of the drug is actually in the blood.
The classic example is alcohol, right?
Exactly. The human liver can process roughly one standard drink, about half an ounce of pure ethanol per hour.
Right.
If you drink one beer, it takes an hour to clear. But if you rapidly consume 10 shots of liquor, your liver does not speed up to handle the crisis.
The enzymes are just maxed out.
It will still only process one shot per hour. The remaining 9 shots circulate endlessly, continually damaging the brain.
So if a medication follows zero order kinetics, an accidental overdose is incredibly dangerous because the body simply refuses to accelerate its clearance.
Exactly. The toxic levels stay high for hours or days.
Okay, we've tracked the pristine mathematical journey of a drug in a textbook. But now we have to introduce the ultimate variable,
The human being.
the human being. Because a textbook drug acts one way in a vacuum, but the patient sitting on your stretcher brings a lifetime of physiological chaos to the equation.
It's never as simple as the math.
Right. Age, weight, environment, genetics, they warp every rule we just talked about. Let's start with the extremes of age.
Infants and the elderly.
Yeah.
They're the most pharmacologically fragile patients you will ever treat. Both groups are highly susceptible to paradoxical medication reactions.
Paradoxical reactions. What is that?
This is a terrifying phenomenon where the patient experiences the exact opposite of the intended clinical effect.
Really? Like what?
You administer a standard benzodiazepine sedative to a terrified toddler to calm them down for a procedure, and instead of sleeping, they become intensely hyperactive, violently agitated, and completely uncontrollable.
I'm struggling to understand why that happens, especially with the elderly. If an 80-year-old patient has a failing liver and failing kidneys, shouldn't their metabolism just be slower? Why do they need fundamentally different doses?
You're touching on the fundamental flaw of treating humans like identical machines. It comes down to massive shifts in body composition.
Knobby composition of it.
Consider body water. An infant is basically a water balloon. Up to 80% of their total body weight is water. An elderly adult might only be 50% water.
Okay. How does that change the dose?
If you administer a water-soluble medication to an infant, that drug diffuses and dilutes across a massive volume of fluid.
Right.
To achieve a therapeutic concentration in the blood, you actually have to administer a higher weight-based dose to an infant than you would to an adult, just to overcome that dilution.
That feels so counterintuitive, giving a baby a higher proportional dose.
It is. Now reverse it for the elderly. They have much less body water, but a significantly higher percentage of body fat.
Ah, the fat reservoir again.
Yes. If you give them a fat-soluble medication, it immediately sequesters into that large fat reservoir. You might need a higher initial dose to get an effect, but because their liver's P450 system is depleted and their kidneys have lost 50% of their nephrons, they cannot metabolize the drug when it inevitably leaches back out of the fat.
So a normal dose easily becomes a toxic, lingering overdose.
Exactly.
Which exposes the massive dilemma of weight-based dosing. In EMS, dosing based on milligrams per kilogram of body weight is hammered into your brain from day one. It's treated as absolute gospel.
It is the standard because it's the safest general approximation. It attempts to scale the chemical dose to the size of the biological container.
But it is deeply flawed.
Very flawed.
I need to understand this flaw. Let's say my protocol says to give 1 milligram per kilogram of a lipophilic drug.
Okay.
I have two patients. Patient A is a 250-pound elite professional bodybuilder. Patient B is a 250-pound patient who is morbidly obese and sedentary. The math says I give them the exact same dose. Does that actually work?
That is the exact scenario where the math fails the patient.
Why?
Weight-band formulas fundamentally assume ideal body weight, a standard healthy ratio of muscle, bone, fat, and water.
Right.
Your bodybuilder is composed of massive, highly vascular skeletal muscle. When you push the drug, the massive blood flow rapidly and predictably distributes the medication to the central nervous system.
But the obese patient?
The obese patient has a vast reservoir of poorly vascularized adipose tissue.
Sponge.
Exactly. If you calculate the dose based on their 250-pound actual weight, you are pushing a massive amount of drug into their blood.
Because you did the math for 250 pounds.
Right. But because the fat absorbs it slowly at first, that massive bolus slams into their central nervous system all at once, potentially causing instant respiratory arrest.
Oh my God.
And then whatever is left over gets trapped in the fat, leading to days of toxicity. You must learn to estimate ideal body weight and adjust for body composition. You are treating the physiology, not just the number on the scale.
What about the environment? Can the physical temperature of the patient really change how a drug works at a cellular level?
Tremendously. If your patient is suffering from severe heat stroke, their core temperature might be 106 degrees.
Okay, so they're cooking.
This hypermetabolic state creates chaos. The extreme heat can literally denature, unfold and destroy the delicate P450 enzymes in the liver, completely halting drug metabolism.
At the same time, the increased heart rate circulates the active drug faster.
Exactly.
And what if they are freezing? A patient pulled from a frozen lake.
Profound hypothermia is even worse. Cellular metabolism grinds to an absolute halt.
So what happens if you push a drug?
If you are running a cardiac arrest on a frozen patient and you push standard doses of epinephrine to restart the heart, it often fails completely.
Because the blood isn't moving.
That, but also the receptor proteins on the heart cells physically stiffen and change shape in the cold. The epinephrine key literally cannot fit into the frozen lock.
You have to warm the patient before the drugs will work.
You absolutely do.
And we can't ignore the hidden landmines. Genetic wildcards. You might do everything right, follow the protocol perfectly, and still trigger a fatal reaction because the patient's DNA is different.
Exactly. Let's look at sickle cell disease.
Okay.
The patient's red blood cells are prone to deforming into a rigid sickle shape under stress. If a paramedic administers a strong loop diuretic to a sickle cell patient for mild fluid overload, the diuretic rapidly pulls water out of the blood plasma.
Which concentrates the blood.
Yes. The red blood cells are suddenly packed tightly together in a dehydrated plasma. This immediately precipitates a massive sickling crisis.
Oh, wow.
The deformed cells polymerize, interlocking and creating microscopic log jams in the capillaries, cutting off oxygen to the organs and causing agonizing ischemic pain.
Another one I read about was G6PD deficiency, glucose 6-phosphate dehydrogenase.
It's a genetic enzyme deficiency.
How does it affect drugs?
If you administer common drugs like high doses of aspirin or certain antimalarials or sulfa antibiotics to a patient with G6PD deficiency, their red blood cells lack the chemical armor to withstand the oxidative stress of the drug.
So what happens to the cells?
The red blood cells literally rupture and explode in the bloodstream, a condition called catastrophic hemolysis.
That is terrifying.
This is why a rigorous, thorough patient history is your greatest diagnostic tool.
And the ultimate physiological shift, would one that rewrites every rule simultaneously? Pregnancy.
Yes.
A pregnant patient is essentially two distinct patients, and the mother's body has completely re-engineered its own cardiovascular and metabolic systems to support the fetus.
The shifts are staggering. To perfuse the massive, low-resistance vascular bed of the placenta, the mother's body increases her total blood plasma volume by up to 50%.
50% more volume.
But because the liquid plasma increases much faster than the solid red blood cells, she becomes functionally dilutionally anemic. Her heart rate and cardiac output skyrocket.
How does that affect the drugs?
That massive increase in fluid volume means water-soluble drugs are deeply diluted. Standard doses might become completely subtherapeutic.
And her liver and kidneys.
Her renal blood flow increases by 50%. Her kidneys are filtering blood at an incredible rate, meaning she will metabolize and excrete renal-cleared drugs incredibly fast.
What about oral meds?
Her gastrointestinal motility slows down to extract more nutrients, meaning if you give her an oral medication, it might sit in her stomach for hours before absorbing.
And on top of managing those profound maternal changes, you have the burden of the fetus. Every drug you push might cross the placenta.
Paramedics must balance the absolute necessity of saving the mother's life against the potential for devastating fetal malformations or fetal death.
It's an impossible choice sometimes.
It is. You must utilize FDA pregnancy risk categories or modern lactation and pregnancy warning databases before giving non-emergent medications.
But in an emergency.
Let me be perfectly clear. The golden rule of emergency obstetrics remains absolute. If the mother dies, the fetus dies. You must aggressively manage maternal airway, breathing, and circulation with whatever chemical weapons are necessary to keep her alive, but you do so with a profound, terrifying awareness of the collateral damage.
Which brings us to the final, most crucial aspect of this deep dive.
The crucible.
The crucible. High-stress pharmacodynamics and error reduction. Because here is the brutal, honest truth. We have spent an hour talking about receptor affinities, bioavailabilities, albumin buses, and P450 enzymes.
Right.
But all of this brilliant microscopic cellular science is entirely 100% useless if you reach into your jump bag in the bark, pull the wrong unlabeled syringe, and push the wrong drug.
That is the ultimate nightmare, and it happens to smart, well-trained medics.
Because the physical environment of EMS is inherently hostile to clear analytical thinking.
Exactly. You are making critical medication calculations based on memory under extreme sympathetic stress.
Often while standing up in a vibrating metal box, going over potholes, with a monitor alarming and family members screaming.
That is the perfect recipe for cognitive overload, tunnel vision, and a lethal error.
So how do we stop it? What are the actual street-level safety protocols that survive that kind of adrenaline?
First and foremost is the absolute unbreakable necessity of verbal readbacks.
Verbal readbacks.
When you use the radio to receive a medication order from a physician at online medical control, you do not just key the mic and say, copy.
Right.
You repeat the entire order back. The drug name, the dose, the route. Copy, administering 1 milligram of epinephrine, 1 to 10,000 IV push.
And you do the same thing with your partner in the rig.
Before you push any drug into the IV hub, you loudly and clearly announce it to the room. I am pushing 100 micrograms of fentanyl, 4 now.
Why does saying it out loud help so much?
It does 2 things. First, it forces your own brain to consciously process the action, snapping you out of autopilot.
And the second.
Second, it gives your partner a 3-second window to look at the syringe, realize it's actually midazolam, and yell, "Stop!"
What about syringe labeling? I see medics drawing up meds during a code and just laying them on the bench seat.
An unlabeled syringe is a loaded, unguided weapon.
Wow.
Never, under any circumstances, place a clear liquid into a plastic syringe and set it down without a label. Not even for 10 seconds.
Because in the chaos.
Because in the chaos of a cardiac arrest, someone else will reach for what they think is a saline flush to push a line. They will grab your unlabeled syringe of epinephrine, and they will inadvertently give a massive lethal overdose.
Just use a piece of tape.
Use pre-made stickers or tear off a piece of white tape and write the drug name and concentration in Sharpie. Always.
We also need to be much smarter about evaluating patient allergies. Because a patient will tell you they are allergic to a drug, but when you actually interrogate them, it's not an allergy at all.
It is a critical distinction that changes your treatment plan. You must differentiate between a true immune-mediated anaphylactic response.
Where their immune system attacks the drug, their throat swells shut, and they go into shock.
Exactly, versus a simple expected adverse effect. A patient will confidently say, "I'm deathly allergic to morphine. It makes me nauseous and itchy."
Nausea and histamine release aren't allergies. They are literally just what opiates do.
Exactly. That doesn't preclude you from giving it if they have a crushed pelvis and are in agonizing pain.
Right.
It just means you need to be a good clinician and proactively drop an antiemetic to manage the nausea. But if they say, "Morphine put me on a ventilator," that is a true allergy, and you must utilize a different class of analgesic.
We also have to watch out for the pharmacy they carry in their purse. Bringing the patient's home medications to the ER is a staple of good EMS, but it's vital for pharmacology too.
Scoop every single pill bottle into a bag and take them. The ER physician cannot treat the patient blindly.
And from a pre-hospital standpoint, you might be dealing with medication interference.
Right. You might be trying to push a heart rate elevating drug, but it's failing because the patient took a massive overdose of a beta blocker that is permanently occupying all the receptor sites.
Or worse, the drug you push creates a lethal synergy with a psych med they took that morning, causing a fatal serotonin syndrome.
Exactly.
We also have to protect ourselves from our own bad handwriting. The Institute for Safe Medication Practices, the ISMP, publishes a list of error-prone abbreviations. You have to memorize it.
It seems trivial until it kills someone.
Right, like writing a U instead of the word units.
If you write the letter U for units and you scribble it fast, it looks exactly like a 0.
And then the next medic looks at your chart.
Sees 10 U of insulin, reads it as 100, and gives a fatal dose. Write the word units.
What about decimal points?
Never use a trailing 0. Don't write 5.0 because the decimal gets lost and it becomes 50.
Like, always use a leading 0.
Write 0.5 so it doesn't look like a 5. And always, always have your partner double-check your math.
Your brain, under the influence of adrenaline, cannot be trusted to accurately move decimal points for weight-based volume conversions.
No, it cannot.
But let's look at the systemic level. If we punish every honest mistake with immediate termination, we don't stop mistakes. We just drive them underground. People will lie to protect their jobs.
Let's take that a step further. Punitive environments breed fatalities.
Because no one talks about what went wrong.
Progressive EMS agencies must actively foster what we call a just culture.
What is a just culture?
A just culture is a psychological environment where paramedics feel safe reporting near misses and honest cognitive errors without the paralyzing fear of being fired or losing their license.
Because if a medic makes a math error because a specific protocol is confusingly written, firing that medic doesn't fix the protocol.
It just ensures the next medic will eventually make the exact same mistake.
Right.
A just culture allows the system to analyze the error, rewrite the protocol, redesign the physical drug bag, and ensure the entire agency learns and adapts. Transparency breeds safety, secrecy breeds death.
Transparency breeds safety. I want you to remember that as we wrap up this deep dive. Let's briefly recap the monumental journey we've taken today.
It's been a lot.
You, the paramedic student, are stepping into an arena where you must deeply, profoundly respect the immense chemical power of the medications you carry.
You have to visualize the cellular locks and keys.
Right. Understanding how agonists violently activate the system and antagonists ruthlessly block it. You have to adapt to the reality of the street, choosing the right route for a VINIO when the textbook veins disappear.
Mm-hmm.
You must anticipate how the patient's liver and kidneys will utilize the P450 chop shop to biotransform and eliminate the drug.
And you must constantly adjust your math for the unique human variable in front of you.
Their body composition, their environment, their genetic flaws, and above all, you must anchor yourself to strict, unbreakable safety protocols.
Verbal readbacks, meticulous labeling, and math double checks.
To prevent your own brain from making a fatal error in the crucible of a crisis.
It is a phenomenal, overwhelming amount of information to synthesize.
But it is the absolute baseline requirement for the patch on your shoulder. You are no longer just memorizing flashcards to pass a multiple-choice test.
No, you are learning how to actively manipulate human biochemistry to pull someone back from the edge of the abyss.
And I want to leave you with one final provocative thought to mull over as you head into your clinical rotations.
Okay.
We talked about receptors today as static locks, but they aren't. They adapt.
They absolutely do.
Look up the concepts of tolerance and tachyphylaxis. If you expose a patient to repeated doses of a drug, their cells will actually retreat, rapidly withdrawing their receptors from the cell membrane to protect themselves from the chemical flood.
That rapid downregulation is tachyphylaxis.
The drug stops working entirely.
Yeah.
As our society becomes more heavily and chronically medicated than ever before in human history, how will the future of emergency medicine adapt?
That's the big question.
Are we approaching a technological horizon where paramedics won't just carry drugs, but will carry rapid genetic and receptor scanners?
Mm-hmm.
Will you one day scan a patient's forehead to mathematically predict exactly how many active functioning receptors they possess before you even dare to choose a chemical weapon from your arsenal?
It is a fascinating frontier. The pharmacology of tomorrow will be entirely individualized.
The science is moving exponentially faster than our protocols, and the variables you will face in your career will only become more intensely complex.
They will.
Good luck out there. Remember the crucible. The sterile diagnostic X-ray machine of the hospital is broken out on the street. You are operating in the muddy, terrifying waters of chaotic human physiology.
Trust your training. Verify every single drop of your drugs.
And always remember, you are treating the terrified, fragile, human patient in front of you, not just the textbook numbers on the monitor. Stay safe.